Dr. Steven Stone, thank you so much for coming to this Lunch and Learn. We really appreciate it. Dr. Steven Stone is Assistant Professor at the Pediatrics in the Division of Endocrinology and Diabetes at Washington University School of Medicine, St. Louis. He specializes in pediatric endocrinology and focus his research on rare metabolic diseases, severe insulin resistance, and atypical diabetes. And he will give us this amazing lecture. Thank you so much. And the floor is yours.
Thank you so much, Ron. I'll go ahead and try to share my slides again. Yeah. Let's see. Is that working okay?
Yep. And if you have any questions, please put them in the chat and we'll get to them after the lecture.
Oh, perfect. Let me see if I can pull the chat up. Okay, I'm able to pull the chat up during the talk. Okay, great. Yeah, thank you so much for this invitation. I tried to put this together for a more general audience, and Sharon asked me to cover some basics about how insulin works, dive into insulin resistance, diabetes. We'll talk about some treatment options, and then at the end, I'll share with you guys some of the research that's been going on in my lab specifically about lipodystrophy. Just really honored to have this opportunity to connect with you guys. Really, I met this community at the last November at the Lipodystrophy United meeting, and it was just probably one of the best academic experiences of my life, getting to see the people that are directly affected by the research that we're doing, and really inspired me to keep working. Oh, and I already found my first typo, lunch and learned. Oops. Okay. I think there's a little bit of an echo. But I thought I'd share with you guys a little bit about me. So I am a pediatrician, a pediatric endocrinologist. I love taking care of kids, is a passion of mine. So I work mainly with children and teenagers, some young adults, but I don't typically take care of old people. I love getting outside when I can. Last year we had a bloom of cicadas, and that was a lot of fun. And then in our lab, we try to do research on interesting individuals with extreme diagnoses. And so that's what's kind of triggered this paradigm of bedside to bench research. And I'm happy to answer any questions that you guys have. Oh, that worked weird. Okay, so I wanted to take a second to dive in just about the basics of how insulin works. And so insulin is made in the pancreas, and there's these specialized cells called the beta cells. And they have their job is to regulate our blood sugar by making a hormone called insulin. And so the beta cells sense insulin in our blood, and they sense glucose in our blood, and when glucose rises in our bloodstream, they stimulate the release of insulin. And insulin is important because that's what lets sugar, glucose, carbohydrates from our bloodstream into our cells, and that can include fat cells and muscle cells. And those are the main source of energy. So they allow the cells to turn that glucose into energy. And by taking that out of our bloodstream, then that is what brings our blood glucose back down into a normal range. And so I thought I'd show you guys a couple other diagrams. So insulin specifically binds to its receptor, the insulin receptor. Oftentimes people think of this as the key that is unlocking the glucose channel, and that glucose channel is called glucose transporter 4, or GLUT4, and that's what allows it to enter into the cell, therefore taking the glucose out of our bloodstream. And the main cells that are taking up glucose in response to insulin are our muscle cells, our fat cells, and liver cells. And those are the main places that our body needs that energy, and that's where insulin is deriving its action. And so, kind of big picture, oftentimes when I think of insulin and how it works, it's always this balance of the cells that are producing the insulin. So those are our insulin secreting beta cells and from the pancreas, and their action on the cells of our body. So our muscle cells, which are called myocytes, adipocytes are fat cells, and hepatocytes, which are liver cells. And there's this delicate balance that is at play, balancing the ability to secrete insulin and for them to derive their mechanism of action. And so when we think of this concept of insulin resistance, this process starts to happen where it takes more and even more insulin to achieve the same effect. So the pancreas needs to be working overtime, making more and more insulin just to take the same amount of glucose into the cells. And that can happen for a variety of reasons. Some is our genetics. That can be both common and rare genetics. It can be fat tissue that is like lipids, for example, can interfere. Inflammation can cause insulin resistance. There can be many causes of insulin resistance that lead the ability to need to produce more and more insulin. And some symptoms of insulin that people can experience, can have fluctuations in your blood sugar, which can cause mood swings, irritability. Those drops in your blood glucose can cause our brain to make us feel even hungrier, have cravings for sweet foods. Oftentimes when insulin is secreted on overdrive, we'll notice some characteristic skin changes. This causes overgrowth and darkening of the skin, which is a symptom that is known as acanthosis nigricans. It can be linked to symptoms of metabolic syndrome. So people can experience high blood pressure, increased cardiovascular risk. Individuals may complain of having low energy, brain fog, difficulty concentrating, and definitely women who have insulin resistance can have issues with something called polycystic ovarian syndrome, or PCOS, which can lead to heavy and irregular menstrual cycles, decreased fertility. Can be very distressing for women with this condition. And so another way that we can think of that balance between insulin secretion and insulin sensitivity or resistance is by looking at these on this curve. And so if you look at this graph, you'll see the green line is individuals who don't have diabetes and have normal ability to regulate their blood glucose. And so if you think of this axis here as insulin sensitivity, so if you're more insulin sensitive, you're moving to the right. And if you're more insulin resistance, you're moving to the left. Someone without diabetes and without any issues with their blood glucose, if they were to become more and more insulin resistant, their body could make up for that by secreting more insulin. But when we think of how individuals develop diabetes, typically what happens in the case of type 2 diabetes is that you both develop insulin resistance, so decreased insulin sensitivity, so you're moving left across this line, but they also will lose the ability to secrete insulin to catch up to that. And so people who are developing type 2 diabetes often become more insulin resistant and unable to catch up to that. And I wanted to highlight that one key feature that's common in individuals with lipodystrophy is very severe insulin resistance. And so if you were to think about someone with a lipodystrophy condition, they're most likely going to fall somewhere at the upper left hand of this curve, meaning they may actually make lots and lots of insulin, but they're unable to keep up to it, and they have very severe insulin resistance. And so that's one way to think of where do people with lipodystrophy conditions fall along this curve, and how is that different than typical, what we call quote unquote typical type 2 diabetes. And that becomes important when thinking about management strategies, as well as what's unique about people suffering from these conditions. And as I'm sure a lot of this audience knows, that there's different ways that we classify lipodystrophy. There's one is if so lipodystrophy is often characterized by loss of the adipose or fat tissue. And the two ways that we characterize it, one is if it's you're born with that, so it's congenital, versus you develop it later in life, so that's acquired. And then another way that we look at it is if it affects the whole body, or if it only affects certain portions of the body. And so when it affects the whole body, that's what we call generalized lipodystrophy. And then often what happens in partial lipodystrophy is that there's regions of the body itself that have no adipose tissue, and then other parts of the body that actually can build up excessive parts of the fat tissue, and that can lead to other health issues as well. And so when we think about the unique symptoms of lipodystrophy, now we're thinking about loss of functional fat tissue. And so you have to think of what are the unique functions of the fat in our body, and how does losing them lead to symptoms that you're experiencing. And so if in a very simplistic way, our fat serves two main functions as a kind of hormonal system in our body. And so one way that we need fat in our body is to store triglycerides, so fat molecules. So it's a storage depot in our body. And so if you lose the ability to store triglycerides or fats from our diet in fat tissue, then they can go and deposit in other places in our body, which can cause damage. And so one of the places that happens is in the liver. And so individuals with lipodystrophy and without functioning fat tissue can develop this process called de novo lipogenesis, which basically means deposition of lipids or fat into the liver, and that can cause inflammation, fibrosis, can even increase risk for liver cancer, and it can cause the liver not to function as well. And that can be very problematic for people, and can be quite severe in lipodystrophy. And so this previously was called non-alcoholic fatty liver disease, but in the last couple of years has had a new acronym that's been assigned to it called MASLD, so macronutrient associated steatotic liver disease is the new name, or MASLD. And then another thing that people without, or key function of the fat tissue is to secrete hormones, which are known as adipokines. And so these are fat-derived hormones that help us regulate our hunger and our body weight. And so these are hormones that you may have heard of, leptin and adiponectin. And without leptin and adiponectin and these signals to the brain, they actually can trigger deep in our brain stems or in our hypothalamus, our feelings of hunger. And so if you're not getting that signal back to the hypothalamus, then it's going to cause you to feel hungry all the time. It may actually increase your body weight in certain cases, and that can actually lead you to then eat more and more, kind of triggering a vicious cycle as well. And so these are some unique things that individuals with lipodystrophy experience out of proportion to people with type 2 diabetes. And so when we think of what is available for lipodystrophy conditions right now, for generalized lipodystrophy, there is available FDA-approved therapy with a medication called metroleptin, which is recombinant human leptin hormone that is given to replace that loss of leptin. But for people with partial lipodystrophy, there really isn't any specific targeted treatment available. And so they're often left to be using typical medications used for type 2 diabetes. And right now, there's not any specific treatment. And so I wanted to cover what medications that we have available that can improve insulin sensitivity and help someone move in this line to become more insulin sensitive, less insulin resistant, and move into this yellow or green area. And so once again, just wanted to remind us, different medications can either improve how much insulin we secrete from the pancreas, or they can improve the insulin resistance in the peripheral tissues. And so I often think of, this is actually from a lecture that I gave to our medical students, what are the ways that different medications can regulate our blood glucose. And so that can cause the pancreas to produce more insulin. It can improve how the liver handles glucose or how it puts out glucose, fat tissue, muscle tissue. Different medications can slow gastric emptying. So they make you feel more full, slow down how glucose gets into your bloodstream. And other medications can actually help our bodies eliminate glucose through our kidneys. And so one of the first medications that is used for people with type 2 diabetes and insulin resistance is a medication called metformin. And metformin's been around for a very long time. And, oh, yes, I see your question about tirzepatide. I will cover that in a second. Thank you. So metformin is been around for a very long time, and people actually don't 100% know how it works. But one of the ways that it works is it decreases hepatic glucose production. And it also improves how our intestines absorb glucose, and it can improve glucose uptake by working on our mitochondria, which are the powerhouses of our cells, so in our fat and muscles, to improve glucose uptake. And then another class of medications is the TZDs, or thiolindene-diones. These are commonly sold as pioglitazone or rosiglitazone. And these guys work mainly in the fat tissue by acting on a receptor called PPAR gamma that has multiple effects, but one is it improves glucose uptake in the fat and muscle. It decreases how much glucose the liver is putting out, and then it also can increase insulin secretion. And then I always think this is a fun fact. Does anyone know what animal this is and why I'm showing this?
Salamander, no?
Say that one more time.
Salamander, no?
No, it's not a salamander.
No?
It lives in the United States.
Gila monster.
Yes. And why is a Gila monster important for this talk? Does anyone know?
I think that's where the GLP-1s came from. Like they found it in there, I guess, first, right?
Yes, that's right. So the Gila monster lives in the southwestern part of the United States. It's the only venomous lizard that lives in the United States. and they described the first description of the GLP-1s or incretins were derived from the saliva of the Gila monster by Dr. John Eng several years ago. And so I thought I'd jump into this a little bit. So this describes what's called the incretin effect. And so this shows the difference between what happens in the individual when they drink glucose versus getting it IV. And it shows the importance of this GLP-1 hormone. And so on the left here, this is someone who's going through what's called a glucose tolerance test. So that's where they would either get an oral drink of 75 grams of glucose or an IV dose of 75 grams of glucose. And you see that if you give them the same amount of glucose, it has the same effect on their blood sugar going up and down between oral and IV. But if you look at the insulin that is secreted, you see that by giving oral dose of glucose, you actually cause someone to make a lot more insulin over that IV dose. And that difference is what we call the incretin effect. And that is because of what is happening with the GLP-1 hormones. And so these GLP medications work in multiple ways. One way that they work is to, like we talked about, causing the pancreas to produce more insulin. But then they also slow down gastric emptying pretty significantly. So that causes individuals to feel more full more quickly and also slow down how glucose is getting absorbed into the bloodstream. But they're also shifting that curve to the right by helping the body also take up more glucose in the peripheral tissues. And so someone in the chat mentioned specifically about the newest class of this medication, which is called tirzepatide. And tirzepatide is unique because it's what's called a dual hormone receptor agonist. So not only does it work on GLP-1, but it also works on a cousin to that tissue, GIP, which has a more specific effect on the fat tissue. And that has had some early, very promising studies in partial lipodystrophy for certain people to be very helpful as kind of a targeted specific therapy. So stay tuned for more for that, but there is definitely some evidence in that direction. And then the last oral medication that I wanted to put on this list are the DPP-4 inhibitors. And those guys work very similar to GLP-1s. They basically increase the GLP-1 that your body is making on its own because they block this inhibitory peptide that is breaking down GLP-1. So it's basically boosting the body's GLP-1 levels. And so they work very similarly, but don't tend to have as much effect on weight when used in type 2 diabetes. And then, as you guys may know, many people with lipodystrophy aren't able to manage their blood glucose with oral medications alone. And so many individuals need to use insulin and a lot of insulin. So oftentimes this is what's called U500 or concentrated insulin that needs to be given to help regulate blood glucose. So I wanted to give you guys in the next just couple minutes just a glimpse into the research going on in our lab on lipodystrophy. And one of the unmet needs that we focus on is on genetic testing. And so many people with partial lipodystrophy in particular, when they go to their doctor and try to order genetic testing, either it's not covered, or if they get it, they get what are kind of inconclusive results. And to kind of pull the curtain back, when we report changes, so variants in the DNA of individuals, we can identify these changes along a spectrum. And so certain things are what we call not pathogenic or benign or likely benign. And these have, between, basically up to 5% confidence, we've seen this before. We know that this is pretty common. We don't think it's likely to affect the protein, or likely on the flip side, we can define these changes as pathogenic, meaning that individuals we've seen this before in this disease, it's very rare, we expect this to damage the function of the protein, and so we're very confident that saying that this causes the disease. But actually the bulk of these differences are what we classify as uncertain, or variants of uncertain significance. And so one of the big kind of boogeymen in our field is that we're doing genetic testing much more commonly in people with rare diseases like lipodystrophy, but then we find things and we're not sure how that affects individuals. And so as clinicians, we don't have good tools to evaluate these variants of uncertain significance. And we would like to leverage a new technology called induced pluripotent stem cells to help close that gap. And so induced pluripotent stem cells have been around for a little while. You may have heard of embryonic stem cells, but in this case, we actually take cells either from a healthy person or from a patient, and you can then coax those cells back into these stem cells that then can turn into any different cell type in the body. And for our purposes, we've developed some new techniques for making fat cells from these induced pluripotent stem cells, so adipocytes. And the condition that we wanted to do first was just to try to see if we can do this in model a well-described, well-known condition called familial partial lipodystrophy type 2, or Dunnington disease. And Dunnington disease, about 80% of individuals have this specific variant at position 482, where arginine turns into a tryptophan. And so we thought this would be a really great way to study this condition. And so this is how we create the cells. And so we actually took these induced pluripotent stem cells. They're called AN 1.1 cells. And we used a technique called CRISPR-Cas9. So that lets us actually introduce that specific variant into these cells. And this process takes about 2 months. But what you can do is, after you've introduced this genetic change kind of in parallel, we first take them to a precursor step, which are called mesenchymal cells, and then into adipocytes. I'm trying to read your question, Debbie. So people with type 1 fit into... Oh, are you talking about here? Yeah. So yeah, I would actually say that there are people with type 1 that also fit into this middle group. I think that overall for lipodystrophy, the incidence of, like, the rate that people get a positive genetic test back is still much lower than we would like it to be. And so I think there actually is a lot of interest in improving genetic diagnosis for both FPLD type 1 and 2. Oh, thanks so much. Sorry. But okay, so we were talking about the differentiation process. And so we were actually able to make these stem cells into fat cells. So this is a stain that stains the lipid droplets red. It's called oil red O. And so you can see that these adipocytes in culture are staining red. And so that shows us that we were able to make the stem cells. And then on the left here, we have wild type cells. So these are normal. And on the right, these are the cells containing the FPLD2 change. And we can expose them to a couple treatments. One is oleic acid, which causes the lipid droplets to swell up, and isoproterenol, which actually causes the lipid droplets to squeeze down and undergo a process called lipolysis. Here we're using a red stain called Nile red, which is similar to the last one that stains the lipid droplets red. And this is a process that we looked at, which is called bulk RNA sequencing. And so this is a plot that we call a volcano plot. And so we look at a couple different things. So this x-axis is how different the gene expression is between the two. And then the y-axis is the degree of basically statistical significance. And so the more up and to the right or more up and to the left is how different the gene expression is between whatever you're comparing. And so in the orange, we looked at what is more expressed in the adipocytes. And so if you're just looking at the wild type cells, we show that we can successfully make these adipocytes because we turn on the expression of a lot of well-known genes that are present in adipocytes. So this kind of was a sanity check showing that we were able to make these cells. But then if you compare the wild type adipocytes to the lamin A or the FPLD2 adipocytes, we saw some really important changes in key genes that regulate adipocyte function when the majority of these actually had decreased gene expression. And then we also wanted to show effect on how these cells operated in terms of taking up glucose in response to insulin. And so here, the higher that the axis goes is the more able that they're able to take up glucose. And so what you see, so as we add more and more insulin into the culture, the wild type cells were able to take up the insulin, whereas the lamin A cells had a decreased ability to take up glucose. And then finally, we used another assay to measure the effect of mitochondria on these cells. And they had decreased oxygen consumption and extracellular acidification. And so another way to look at that is that from a mitochondrial energy standpoint, these cells went and became much more quiescent, so not able to utilize their oxygen and glycogen functions. So in conclusion, from this project, we found that these cells can differentiate into adipocytes. They had decreased glucose uptake, they became quiescent, and had decreased expression of key genes. So this was kind of a first step for us as part of a bigger project where we're hoping to, really understand the genetics. And we're part of a clinical trial called the Rare and Atypical Diabetes Network, where we've now identified 9 more individuals who have interesting genetic changes. We want to do a lot of the same things that we did here to look at people with kind of non-classical forms of lipodystrophy, do these same experiments and see if we can use these same tools now to say, hey, we found this change in you. We do think that it is responsible for lipodystrophy. And so just wanted to say thank you to you guys and thank you to my team. The individual here, Alouette, she actually performed the experiments that I just shared with you guys, and we're working on getting that published right now. So yeah, thanks so much. I'm happy to answer whatever questions you guys have.
Amazing. Thank you so much. Anyone has any questions? You can unmute yourself or you can put it in the chat.
I do have a question. I know this is a little bit like out there in left field, but have you done any research or have you hypothesized whether or not like just regular mesenchymal stem cells would be of benefit to people? You know, the stem cells are always like a big talk right now, you know, stem cells for your hip pain and your back pain and stem cells for this, but would the high quality mesenchymal stem cells be of benefit to people with, you know, these types of lipodystrophies and metabolic dysfunctions?
Yeah, that's such an interesting thought. I think there's a lot of trepidation, I guess I would say, before jumping into doing something like that, but I haven't seen that study done yet, and that's something that you could potentially try first in mice before doing in people. So for example, a mesenchymal stem cell has the ability to still go into multiple different types of cells, one of which is bone cells, which wouldn't really be helpful for people. In other stem cell based studies, if you kind of get the cells far enough along, can you coax them to kind of get the rest of the way there, is kind of what I'm saying. And so I think there's actually a big idea that is if you could create a cell replacement therapy for individuals with lipodystrophy and have, a depot of healthy fat cells that you could transplant into them, then that could really help reverse some of the metabolic defects that individuals are having. And it may not take a ton of cells. And that's something that Dr. Oral and I have talked about a lot is, could you get them? And so I don't know if the answer is to just do mesenchymal stem cells or if it's actually to take them all the way there, or could you, for example, take somebody's, how do I say this? Could you take somebody's specific variant, correct it from their induced pluripotent stem cells, and then give it back to them, with what we call GMP grade tissue products? I think those are all things that people are thinking about right now that I think are very, very important questions and ideas. I hope that answers your question.
Yeah, I mean, I have an aunt that has lipodystrophy as well, and but she has a lot of back pain and she has a lot of hip pain, and she did get some stem cells. I'm not sure if they were the mesenchymal ones or the adult stem cells, or specifically like which one she got, but she did get a lot of relief of different associated symptoms that go beyond. They weren't specifically focused on the type 2 diabetes, and actually she doesn't, like, her diabetes is not really severe. So it's interesting, like how some people have the same variant and have, differing degrees of metabolic dysfunction. Like some people have the really high triglycerides and cholesterol and the lipid you know, problem, but some people don't have the lipid problem, but they have the significant, you know, insulin resistance. And, you know, I know they're linked together. I understand that, but it's just
Sure.
strange how they show up slightly different.
Yeah. So two things addressing that. I think most likely what your relative had was actually undifferentiated stem cells. And typically when they go into joints, they may not migrate to other parts of the body and things like that. But under the, I don't claim to know everything. And so potentially just having a little bit of cells that have a metabolic effect could be beneficial. So that's really helpful food for thought. And then the second thing is, that's also something that I'm interested is, what you touch on is what we call genotype phenotype correlations. And so why does two people with the same genetic change have different issues? Is it environment? Are there other parts of our genetic code that are affecting that? And so I think those are important things for us to focus on in our research. So great questions.
Okay, thanks. We have a question from the chat. Do you specifically focus on researching pediatric lipogene genetics? How is genetic information collected for your research?
Yeah, that's a great question. So the majority of the patients for this specific project are through the Rare and Atypical Diabetes Network, which does enroll both adult and pediatric individuals with lipodystrophy and other atypical forms of diabetes. So both adults and children. Just me as a clinician, I only treat up to 21 years old. So in terms of how we collect genetic information, we do a couple things. So one is we do what's called a pedigree, which is a detailed family tree. And then we isolate individuals' DNA from a blood sample. And we also do a couple other what we call omics techniques. So we do whole genome sequencing, which looks at every single base pair, the A, T, Cs, and genes throughout the entire genome, so the entire genetic code. RNA sequencing looks at, so we have DNA that then becomes RNA. So that's how much those genes are being transcribed, so turned into the instructions to make protein. And then metabolomics is actually looking at all those intermediate proteins that are key functions for the body. So for example, ketones, lipids, proteins, amino acids, and looking if there's any changes there. And that all gets analyzed in detail.
So how do patients can be involved in this kind of research?
Yeah, so I can put in the chat the link to the Radiant study. And that is a online like sign up form that you can sign up for, and then you can also have the information for your doctor. Oh yeah, thank you. Someone put it in for me. So you can put it in to link information from your doctor, in which case they can also kind of say what makes you unique about your form of lipodystrophy. Just to be clear, someone who had, for example, a known form of lipodystrophy that had a clear genetic finding, they wouldn't qualify for Radiant. We're really looking for people who have unclear genetics as part of it. So that would be just to not have anyone be disappointed.
Amazing. Any more questions? Okay, I have some patients sent us questions before the lecture. Can you explain the difference between insulin resistance and diabetes? Because sometimes we see patients with insulin resistant, but the A1C is lower than 6.
Yeah, that's a great question. So if you guys recall, so I was showing that curve before, and so Insulin resistance is a process that may or may not have lead to diabetes. And it may eventually or it may never lead to diabetes. And so our bodies are able to tolerate a degree of insulin resistance without going on to developing high blood glucose. But at some point, if either you're unable to make enough insulin to catch up to that, or if the insulin resistance becomes so severe that there's just no way to meet the demands, then someone can develop diabetes. And that is something that could be permanent or it could be transient. It depends on the unique situation.
And should you treat children or teenagers with insulin resistance prior to them developing diabetes?
I would argue, yes, that we should try to treat people early and try to focus on insulin resistance to try to prevent or delay the diagnosis of diabetes. That would be my argument.
Yeah. Okay, another question. What came first, insulin resistance or PCOS? Because both of them are connected to one another.
Yeah, it's a really good, insightful question. In my opinion, insulin resistance is likely the cause of PCOS. PCOS is kind of a misunderstood condition. People think of it as either a disorder of the ovaries producing too much androgen or a disorder of the pituitary gland not sensing insulin and then leading to dysregulation of pituitary hormones. And so I think sometimes gynecologists and endocrinologists look at the same thing differently. But in my opinion, insulin resistance is kind of the central thread that links those together.
Right. I have a question. You talked about the liver. So one of the questions that comes up in our Facebook group a lot is those lipids, triglycerides, that are stored in the liver. Does the liver produce them, or are we getting all of the triglycerides from our food?
Yeah, so I think the answer is actually both. So insulin resistance itself can trigger this process that we call de novo lipogenesis, meaning it's making the liver cells produce, they're depositing fat inside the actual tissues of the liver. But at the same time, there is uptake. So because the fat tissue can't be deposited, or the dietary fats can't be deposited in the fat tissue, then that's actually the substrate that the liver is using to lay down that fat. And so I would answer that as both. And so potentially a very low fat diet could be helpful for certain people.
Amazing. One more questions we got. What is the safest drug for severe insulin resistance in a 15-year-old? I know it's you need to check the patient first, but if you have some general thoughts.
I want to make sure I'm not giving any specific a medical advice. So what is approved? So approved medications include at least in the United States where I practice, is metformin is approved to treat insulin resistance. And then a couple of the GLP-1s are approved to treat insulin resistance 12 and up, including dulaglutide and semaglutide. And liraglutide would also be approved. And I think in the right patient, all those would be safe to use as long as, you know, appropriate screening labs were done first.
Any more questions? No? Okay, so to finish up, do you have any general advice for the lipodystrophy patient?
Oh yeah. I guess my advice is to advocate for yourself, and make sure that you're being listened to. And finding specialists that can work with you. I think the smartest patients live the longest and do the best. And so educating yourself about what you're dealing with is super important. And then really advocating for yourself. I know, at least in America, and I imagine elsewhere, the medical community is really difficult to navigate for some people. And so if you don't feel like you're getting the answers that you need to get, your intuition's probably right, and just keep looking out for yourself and or your loved one if you're helping take care of them. Yeah, that's my 2 cents.
Perfect. Okay, thank you so much. It was an amazing talk. We learned so much. Any other questions before we finish this conversation? Okay, now I see the chat. How can we best advocate for ourselves with insurance?
Yeah, that's a good question. So in terms of navigating insurance, I think it's trying to fight hard enough to talk to a human. And so there's a lot of ways that you can do that. And so, you know, working with your doctor, if you need to like provide papers or studies, anything like that, I think is helpful. There's actually some tools that are now make it easier to write letters of appeal, which I find helpful. I don't know if, you know, for example, does Lipodystrophy United, if that's something that you guys do, like providing form letters or anything like that. Sometimes advocacy organizations might help you too. I think insurance is so complicated, but if you're annoying enough, but like you can usually get through, but you have to be very patient, and you have to, like, I always think as long as you could talk to a person and get past the machine, like you're so much more likely to get a positive answer, sort of thing. So I always just try to see if you can break down. They purposely make it so difficult to navigate. Yeah, don't bother if they hate you. Just don't take it personal. Just be rude. It's okay. Yeah.
Yeah, so Lipodystrophy United, we are looking for someone to help us build tools for the community with insurance. But I guess that if anyone has any problem with insurance, he or she can contact us, and we can provide some medical articles or scientific articles that can help, or maybe some direction. But this is something that the community needs, definitely, and we are working on it. Yeah. Okay, thank you so much.
Yeah,
It
thank you.
was a great talk. Have a great weekend, everyone. And we will see you next month for the next Lunch and Learn. So thank you so much.